on to some body cases. I guess I wanted to kind of go over these. These are some of our specialized abdomen protocols. And I guess I'll preface this by saying that these exams, this is not the routine abdomen pelvis. These are kind of tailored exams for a specific question. So generally, the recommendations should either be coming from one of us, because there's something they saw in another imaging study that they need to evaluate, or it's coming from somebody who sort of knows what they're looking at. A lot of these cases, kind of like a red flag. If you see a multi-phase exam on a patient that's younger than 40, you want to maybe question the indication. Again, some of these come from primary care docs who might not be familiar with what the protocol is for. And just with young patients, we want to avoid the excess radiation. So that is kind of an inappropriate imaging to do, if there's no real indication for it. So I wanted to go over these just so kind of familiarize yourself with. This is kind of the majority of the indications for these cases that you'll see. And if they don't fall into one of these categories, you want to kind of maybe question it and go over with the RAD. So the first one is the renal mass protocol. This is for characterization and staging of a known renal mass that's otherwise indeterminate. Either they had a CT scan, they saw a mass that they couldn't call as a benign cyst, or something else benign, or an ultrasound or something, so now they're doing the CT. We're trying to push these cases, these renal mass cases, over to do MRI with, kind of like with a lot of these. We're trying to prefer to do these with MRI, but you'll still see orders for this, and there's still good reasons to do the CT versus the MRI. So when we look at renal masses, we're looking for we're looking for signs that we can call something definitely benign. So in the case of renal masses, we're looking for macroscopic fat, where we can say, oh, this is just an angiomyolipoma, it's benign. Something that doesn't enhance, like complicated cysts can have this intermediate density appearance. If you were seeing this mass just on like a renal stone protocol and it measured 40 Hounsfield units, you can't tell the difference between like a benign hemorrhagic cyst and then this renal cell cancer. So this is the multiple phases. This is the non-con, nephrographic, pyelographic phase. You don't really see it well, but you see the contrast in the collecting system. And so you see all the enhancing tissue in the center of this mass. So that's basically what we're looking for these. The key protocol elements is we're really just going through the kidneys. We're not evaluating the lower tracts on these exams. So we're just doing we just need through the kidneys or through the abdomen. Non-contrast, nephrographic, and pyelographic. So these are 3-phase exams.
Yeah, fight here, see that 4th phase, I see it all the time. Just gonna like fight
That's
it.
on the protocol.
Renal mass?
Yeah.
That's on the new protocol. It's a 5-minute delay.
5 minutes early is the pyelographic phase.
But then there's like an arterial intervenous.
Some old protocols had the corticomedullary phase, which is a little bit earlier. You could see the differentiation between the renal cortex, which goes around, and the renal medulla, which histologically it's different tissue, so it enhances differently at that point. It's not critical for detecting just regular enhancement.
So
that's.
I'm sorry. Demographic would be about.
That's the 100-second.
That's the 100-second, yeah.
Yeah, that's definitely not on the new one.
Okay. Well, we're
Okay.
Dr. Sexton are meeting tomorrow.
Yeah.
Yeah.
So
Is that?
we need to get that in.
So it's 3 minutes or 5 minutes?
5 minutes. We're trying. Really, like 3 to 5 is not critical. We just wanted the same for.
Right.
Gotcha.
So that's why it's going to just
Yeah.
one or the other.
Exactly. Yeah. 3 minutes.
So you're cool if we nix the arterial phase.
This corticomedullary phase. Yeah. I'll mix that on the protocol.
This is a binary process. If it's solid, it comes out, and we can't tell the difference most of the time. And if it's not solid, then it's probably cystic. So it's not like some crazy science.
Right. This is kind of what we're looking for. Any questions about the renal mass? We're going on to the CT-IVP. This is the urogram, which is a split bolus with the non-contrast abdomen pelvis followed by the split bolus abdomen pelvis. the vast majority of these are going to be evaluating painless hematuria in older patients. We're looking for filling defects in the ureters, so the contrast is filling the calyces in the ureter, and then we're looking for things like this. This little mass that grows from the epithelium that lines the ureters, the transitional epithelium. So yeah, the workup for painless hematuria would be one of these to evaluate the kidneys and ureter, and then they're usually followed by a urologist who will look in the bladder with a cystoscope, just because we can't completely evaluate the bladder with this. There's contrast kind of layering too low, and there's not enough sensitivity, so they will look in the bladder if there's still a question. Again, key elements, it's a KUB, so through kidneys and bladder, we have a non-contrasted split bolus that's performed in the nephrographic and pylographic phase. I think we talked about this a while ago about the pre-hydration protocol. A lot of people would try to tank up patients with IV fluids so that they'd be excreting a lot of urine to make sure we get contrast in all the ureters. Recently, the data has come out has shown that that's not absolutely critical, and the best thing to do is just have the patient drink oral, take oral hydration before doing these, just so that they're full of fluids and they have fluid going through their collecting system. And I would say if you don't, sometimes we do repeat delayed sequences. If you don't see sections of the ureter, I would say do that once. You don't need to do it any more than that. The likelihood of significant pathology in the ureter that otherwise looks normal is so low that it's not worth the benefit of all the extra radiation. So those are the CT IVPs. And again, these are the research has shown these are very low yield in patients younger than 40 years old. Transitional cell carcinoma and renal cell carcinoma are typically diseases of older patients. So these have been shown to be very low yield in patients under 40. So we're trying to discourage doing these patients younger than 40.
So we can definitely bag the hydration, no more.
We're not. I mean, that kind of came out with the saline shortage.
It just made Touchstone very happy.
Yeah.
But the oral works really well. It works much better than the IV. I think.
You know what? There's a lot of data that's showing that a lot of this IV hydration we're doing kind of on the floors is not as effective as just having patients drink. So I think a lot of that is starting to come out.
The only problem is if we tell them to drink too much. We had a patient who literally got up to go pee about 5 times during the exam. It was ridiculous.
When we were given the saline as well.
No. Well, you're right. Actually, that one drank and we gave saline. It was not a good company. We only gave her 250. But
Idiosyncratic. Yeah.
But you're exercising in between the boluses too.
What's that?
So we're exercising them between the boluses too, like get up and walk around the table.
Is that yeah?
That's what I usually do. That way it moves the group. So.
Any other questions about the IVPs? Moving right along, we've got a few more. The pancreatic mass protocol. So they're really the two main indications of following characterizing or staging a known pancreatic mass that is otherwise indeterminate. And they're sort of two separate cases. The first question is it a pancreatic adenocarcinoma? These are aggressive tumors with really low survival rates and that have basically been flatlined for the past several decades. We can do a Whipple if we can catch it early enough, but other than that, it's merely a uniformly fatal diagnosis within 5 years. So for pancreatic adenocarcinoma, CT is actually preferred. The spatial resolution that we get with CT helps us figure out the tissue planes around all the critical structures around the head of the pancreas. Most of these tumors occur in the head and unsafe process. So we are looking for signs to tell the surgeon whether this is resectable or unresectable. So we need to see if these tumors are encasing the superior mesenteric artery, the superior mesenteric vein, the portal vein, and that information the CT has just better spatial resolution. The other flavor of pancreatic mass are the cystic masses. And these are kind of a hodgepodge of lower grade, malignant, pseudo-malignant, less aggressive tumors that a lot of times we end up following just because they're kind of indeterminate. These we actually prefer MRI just because the additional sequences give us more information. And these we typically follow over time, and these again are sort of more of those lower grade neoplasms that we want to follow for a long time to make sure that they're stable. So a lot of times we'll follow these for up to 5 years, and so it's better to use MRI if we're going to be imaging them on a repeated basis. But again, like the key protocol is through the liver and pancreas. We also want to see the liver and looking for metastatic disease. We do a non-con, the late arterial, which is kind of the pancreas, which is about a 40 to 50 second delay, and then the standard portal venous series. Any questions about pancreatic mass?
Those are pretty close together. I'm sorry. The
Yeah.
arterial and the venous. So you're talking if it's 40 to 50 seconds, and the venous typically is like 75 seconds. So
Yeah, it's kind of one after the other. And it's very similar to the liver mass protocol, CT. These are for characterization or staging of a known liver mass that's otherwise indeterminate. Again, we're trying to do these more with MRI. These liver masses, they're just a little bit more specific. And that's sort of what we're doing. But CT is, again, it is considered, a first-line test. And again, we're looking for things that are benign, saying this is a hemangioma. Yeah.
Can we go back to the pancreas?
Sure. Yeah.
I think in our protocol it says to drink bouillon before.
At
See,
rat's
that's-
discretion, yeah.
Yeah, I heard that before. We're just doing the water prep for these.
So we can scratch.
You don't need to do balloon for these. Yeah, no, I know that. I thought we fixed that a while ago. Yeah, I'll just have the patient drink. We want to have some water in the Georgina suite, but that should be fine. So, but if that is still an issue, I'll roll out the curtain. That all straightened out.
Yep.
Liver mass, back to liver mass. There are benign masses that are not, they're benign, but they're not exactly leave-alone masses. Focal nodular hyperplasia, hepatic adenoma are masses that sometimes end up being resected. So they're not malignant in terms of like they won't metastasize, but sometimes the treatment and management can be more complicated. And then we're looking for things that are either probably malignant or indeterminate enough that we want to expose the patient to the risk of doing a liver biopsy. So HCC, a lot of patients with cirrhosis. It's interesting epidemiologically that the most common cause of HCC in the last several decades was hepatitis C and alcoholism. Now it's becoming, since the hepatitis C population is kind of tailing off, they've got some new cures and now they screen for transfusion, so a lot of the risk factors for HCC have been kind of taken care of. But now the biggest one is the fatty liver disease, which is sort of part of that metabolic syndrome. Again, through the liver, there was like the hemangioma one, and I think we can just do this one. We'll do the non-con, the late arterial, which is a little bit earlier than the pancreas late arterial. And this is sort of the difference of why it's critical to get a good late arterial phase image. If you look at this exam, this is sort of in that early arterial. This is almost like an arteriogram. The only thing that's really lighting up is the aorta and the hepatic arteries. And if you were looking at just this image, maybe there's something there, maybe not. But then when you look 17 seconds later, you see this just big infiltrated mass. All the parenchyma of the tumor kind of takes up this blush of contrast. These tumors are fed by the hepatic artery, so that's why they enhance early. So that's why it's critical to do this late arterial phase at a good point. Then we just do the routine portal venous, and then a 5-minute delay. A lot of tumors are either looking for late enhancement or late washout, so the 5-minute delay is critical.
Should we be doing that in MR as well, the later time?
The contrast timing I should be almost
see hepatocellular carcinoma, yeah, if you have 5 seconds of the regular arterial phase, is pretty helpful. Like the normal liver gets about 70, most of the blood flow from the portal vein, and meds and HCC get most of the blood flow from the artery. So if you give contrast, in later arterial phase, like Ben was saying, stuff that gets blood flow from the artery is going to enhance faster, which just stands out. And that's really one of the criteria that MyRAS is that it enhances faster than everything else. So having a good late arterial is pretty much one of the most diagnostic features in the work of these. But again, for rare reason. And now that you can treat hep C, probably become even more rare. So.
And a lot of these patients are followed in the hospital, or like Dr. Rader and Dr. Shaw will do directed chemotherapy on these, and then we follow them up over time. We don't see a lot of these in patients there.
And you're supposed to be able to diagnose it with imaging, but nobody believes us. They biopsy anyways, so it's like, I don't know, it's not as critical, but the literature would say that you can diagnose it. It's a diagnostic of HCC, but, whatever.
All right, two more. This one comes up every once in a while, the adrenal mass. This is for characterization of usually an incidental adrenal mass that's usually seen on either a non-con CT that you can't call it benign, or a contrast enhanced CT where you're not sure. What we're looking for is the vast majority of these are just benign adenomas. They're just sort of incidental things that actually a lot of people get, and they're whether they're functional or not is sort of a clinical question from an imaging standpoint. We just want to know if they're benign or malignant. So we're looking for these little nodules, and if they measure less than 10 Hounsfield units on a non-con, then you can confidently say this is a benign fat-containing adenoma. The adrenal glands secrete corticosteroids, which are like it's a lipid molecule. So we're looking for low-density, intracellular lipid on these. If it's above 10 Hounsfield units, or if it's on a contrast exam, then we have to go and do this washout protocol. These adenomas, if they're benign, will wash out contrast more rapidly than other malignant lesions. So that's kind of the key differentiating factor we're looking for. So if you get an order for one of these, it's usually some incidental thing. A lot of the times we'll, if you have the RAD on site, check the non-con, because sometimes, say, if the patient had a contrast routine abdomen and pelvis and they saw this incidentally, and they do a non-con and it's low density, you can stop there. So check with the RAD before going on injecting the patient and doing the extra images. If not, then you have to do the extra images and kind of put ROIs over the little nodule and plug it into this formula. And if that number comes out to greater than 60%, then the specificity and sensitivity is extremely high. It's just a benign adenoma. This is an exam where at least I prefer CT. MRI you can do a chemical shift MRI in an out of phase sequence, and if you see signal drop out on the out of phase, you can say that it's contains lipid and it's benign. But if you don't see that, these washout calculations have not been validated for MRI. So those you can't plug MRI enhancement numbers into that formula and have it be valid. So if it's a lipid poor lesion, I think CT has kind of better specificity. And this is just through the abdomen at 60 seconds and then a 15-minute delay. So, any questions on that one?
Through the adrenals or through the abdomen?
It's just through the abdomen.
Okay.
Yeah. Just stick to the abdomen. Last one is that we do is CT enterography. These are evaluating patients with inflammatory bowel disease, with Crohn's disease. We're looking for active bowel inflammation, secondary acute complications like fistulas or abscesses, and areas of stenosis that relate to the bowel wall. When the inflammation kind of subsides, there's a fibrotic reaction and scar down the bowel and create a stricture. These are also, we prefer MRI for these, to do the MR enterography, because these patients are often young and they get imaged over and over again, so people are trying to be cognizant about their cumulative radiation dose over the span of their lives. But we do do these, and they can provide a lot of valuable information. This is the only protocol I think that we're using with lumen prep right now. And that is fairly critical. We do want to have the bowel well distended so that we can see the mucosa and have the bowel roots kind of separated, looking for any significant pathology. And then other than that, it's just a routine abdomen pelvis in terms of the coverage and the contrast levels. So again, I just wanted to go over these that are multi-phase and our specialized body exams are usually kind of tailored to a specific question. So the indication should sort of match up with the protocol, and if it doesn't, that's, we don't want to be doing inappropriate imaging, so check with the radiologist to make sure we have the right protocol. And again, a lot of these, except for the pancreatic adenocarcinoma and the adrenal mass, we're trying to shift the bulk of this work over to MRI. You can see that.
So the protocol that saves 60 seconds already?
For the adrenal?
No, for the entry.
Oh, for the angiography?
Is that, I mean, it's 15 seconds did, but.
I'll look into that. I think Kirk and I are going to go over all the protocols tomorrow, and we'll get that out to you.
And do you have any experience with the Brisa type lumen prep? They have Brisa makes one. as
Is
well.
that, yeah, I heard, is that
It's
like
supposed to be more tolerable.
good tasting stuff?
Yeah. It's like lemon wine or something.
I should subject myself to perhaps just to see what it's like.
Actually, it brings water, has a little bit of.
That's right. All right, any other questions, anything else I can ask you?
I have a loaded question. On patients that, like our doctors have gotten, we did the ultrasound in one of our touchstone locations, and they suggest that they come back for like CT or MRI with contrast. Can they say for sure, like with contrast in the notes, instead of just saying come back for CT?
You mean in our reports?
Yeah.
Yeah, we've discussed
Is that a
We're-
big deal or what?
Yeah, if there's an issue, like, let us know, because we're trying to tell
The
everyone.
lack of
specific.
specificity
Yeah.
nails us.
Yeah.
Dr. Jonas is the worst.
CT or MRI will
He'll say,
contrast.
recommend MRI with contrast when he means with and without. We know that's what he means. You call the doctor, they argue with you.
Yeah.
Right.
You know, say, no, he said with. Well, he doesn't want two sequences, he wants one.
We've said this to the Reds like
It was, so Stephen was really vocal about that, he brought it to my attention, and so we started talking. I just talked to Dr. Barrow recently, and she promised as well. So if we do, if it can, I guess just.
I know we're not going to get it from other radiologists, like if we get stuff from Health Images. We know whether we're not going to get them to do it, but at least our own docs.
Yeah, you gotta call it
Yeah.
out.
Yeah, that's something we're trying to be cognizant of.
Yeah.
It has gotten better, it really has.
Yeah.
It used to be multiple times a week, less than that.
It's probably